So just to get started, good evening, everyone. My name is John Murphy. I'm a project coordinator for Behavioral Health Network of Greater St. Louis. I would just like to welcome you all to the second episode in this webinar series. This series focuses on a collaborative approach to identify and engage youth that misuse substances. So this webinar series was put together by Behavioral Health Network and Preferred Family Health Care staff. It is designed to be informational and create dialogue surrounding potential new steps in community collaboration. So through our goal audience, though our goal audience are professionals and providers that work with youth and families, we welcome any community member that's interested in learning more on this subject. So as I mentioned, the title of our webinar series, this is our part 2 of a collaborative approach to identifying and engaging youth misusing substances. Just to have a little bit of housekeeping, just because, make things go as smooth as possible. We had our first episode, like I said, last week, and I think everything went relatively smooth, but we did have a few technical issues here and there, so I did solicit a little bit of help from one of my coworkers just to kind of manage it and everything. But if you did see any problems that you wanted to let me know about, just go ahead and shoot me a chat directly. But all questions, if you did have any questions, and definitely hope that you do, they will all be answered at the end of the webinar, just to keep time. Though we do encourage participants to submit their questions ASAP, because we don't want you to forget your question at the very end. We do ask that if you could please utilize the chat feature or email your questions to me. My email address is jmurphy@bhnstl.org. And you can also, if you're watching this on Facebook Live, you can also email me at that email address with your questions. You can comment with your questions, and if you did want to get any of the slides or the presentation materials at the end of this specific episode, make sure to shoot me an email as well, and I'll make sure that your email address is on my list. It looks like Kate just let everybody know that if you're able to mute on this during this presentation, that would be great. And then if you did have any questions, you can either, like I said, shoot them on here or shoot me an email. As I also said, all of the information is being, or this episode is being recorded, so all the information will be able to be disseminated to all of you, because I do have all your email address registration. Again, if you are on Facebook chat or if you join this without registering, again, just shoot me an email. I will make sure that you're on that list so you get all of the supportive materials that we'll be going through today. So I did this and talked a little bit about this during our first episode, but because some of you may not have been on that episode, I wanted to just start a little bit with what led to this webinar and why, or this webinar series, and why this was something that was created. So as I mentioned, I work for a behavioral health network at Greater St. Louis, and my specific position focuses on identifying barriers for early identification, intervention, and the referral of youth with substance misuse needs within the Greater St. Louis area. So through this work and speaking with various organizations, community partners, it seemed that there were a few themes surrounding youth substance misuse. For instance, the first one that I've heard about from various partners are that partners that work with youth and families agree that it is something that needs more attention, especially within medical office framework. Second thing that I've heard a little bit and I've seen experienced is that COVID has impacted outreach and engagement efforts surrounding how behavioral health services are conducted. And number 3, there was a lack of knowledge on how to intervene and engage youth substance misuse and knowing specifically where to refer. So this led me to believe that the Greater St. Louis area may need to look at youth substance misuse through a more collaborative lens between those that are doing similar work within youth substance use, but also for those that work with youth and families outside of substance use treatment that may have intersecting needs. Some thoughts that were raised with myself when I was thinking about this was, for instance, should we as a region start focusing towards substance use prevention as a means to decrease violence? Can substance use screening be integrated with other routine topics that youth get checked for during child visits or routine doctor's appointments? How can we, within the COVID environment, really look at behavioral health navigation and outreach efforts? And so with all of that, keeping all that in mind, it really led me to, number 1, a need for collaboration. Number 2, COVID has changed the landscape of how focused populations are outreach and engage. And number 3, a desire for innovation and strategy surrounding youth substance misuse. So keeping all that in mind, that's really, I think, what led me to want to do this and conduct this series. So just to give you a little bit of overview for what you'll see tonight and other episodes that you'll be able to either see in the next few weeks, or if you weren't able to attend the one last week, it is recorded and I can definitely provide you information on how to access that. So due to all of the intersecting topics that I mentioned, I began to identify some key aspects that I thought that could be really good to start with this dialogue. So you can see through the 4 different topics in the titles that were, you can kind of see like what the focus areas I've identified are. My idea and kind of my perspective on this series is to have it set up both overall and within each episode through an attempt to create like larger level observations and trends down to more individual and on the ground work. So for instance, if you attended the episode from last week, you learned about a broad overview of the eastern region of Missouri and what various data tell you about youth substance use and the perspective of a youth worker within substance use treatment. So really like a top-down approach in considering what within the overview of the landscape of youth substance use do we really need to look at and how should we be looking at that. So specifically with this evening and tonight, we will be hearing from 4 medical professionals that combined have decades of experience working within various medical institutions to enhance conversations and screening to identify youth and families that are in need of additional services and resources. We will be specifically talking about youth substance use, but they are also individuals that have had great experience with other kind of needs and conversations around and issues that youth face. Just to kind of give you a little bit of a hope of what my thoughts are around what I hope the outcomes are of this episode is we can start considering how we can intentionally talk with youth and families in provider settings where substance use may not be the primary reason for the family coming in to receive care, but by having screening tools built into databases, paperwork, the processes that you have within your offices, for new or existing patients, we can begin to provide a space to destigmatize these conversations around sensitive topics. Specifically talk about youth substance use, but I think that these can kind of go to other topics that are sensitive, like sexual health and so on, to specifically enhance discussion with youth and families. To summarize this idea, I want you to think of this throughout this episode and after. Specifically, how can we help youth and families identify what services they need if we as providers do not ask questions in a way that solicits open and honest dialogue? So I provided this slide last week too, but I just wanted to let you know all of the amazing individuals that are involved in this webinar series. I'm not going to go and say every name, but as you'll see through this list, we have a lot of different partners that are helping with this specific episode, and the speakers are specifically being from these different organizations. So I just want to say thank you so much for all of your efforts and your time, and really a special thanks to the speakers that are being involved in this series. The last thing I want to say before I begin the actual presentation from our speakers is some of the prospective outcomes from this series. We do, number one, want to kind of think of youth substance use within a more preventative approach. So really shifting youth substance use conversations to include a preventative approach. Number two, I want to help and create some systemic changes and really soliciting advice and dialogue from all of you as the individuals listening to this. So beginning initial conversations surrounding a need for systemic changes. Number three, we want to think of new collaborations and really bring various community partners to the table that's voices maybe weren't thought about when it comes to youth substance use, but really thinking about how those different type of collaborations or those different partnerships can really collaborate and work and have crossover and intersecting conversations with youth and families. We want to, number four, create action-oriented steps. We really want to create some realistic and action-oriented steps towards coordination within the community. And then lastly, and really what the 4th episode of the series will highlight, is understanding the COVID impact and understanding how substance use treatment and other youth-oriented programming will be impacted by COVID-19. So just an outline for what you'll be expecting and really just to give you a little bit of idea what we'll be hearing from tonight. Our first speaker of this evening will be Michele Herndon. She is a manager of trauma services and EMS outreach with St. Louis Children's Hospital. We then have John Dalton, who is a licensed clinical social worker or a pediatric medical social worker with St. Louis Children's Hospital. We will then have Dr. Fred Rottnek, an MD and a master, which Off the top of my head right now, I'm forgetting the acronym, but I definitely have it when I'm introducing him. He is a professor and director of community medicine and family medicine at St. Louis, at St. Louis University School of Medicine, and is also a program director for addiction medicine, for the Addiction Medicine Fellowship. And then lastly, to round everything up, we have Maggie Graf, registered nurse, and the director of health education from IFM Community Medicine. So first to introduce, we have again Michele Herndon. She is again the manager of trauma services and EMS outreach at St. Louis Children's Hospital. Michele began her career as a pediatric emergency nurse. She has been the manager of trauma services and EMS outreach at St. Louis Children's Hospital since 2018. Besides her passion for injury prevention and the care of the pediatric trauma patient, she also has a passion for the care of the hospitalized adolescent, having been through many hospitalizations with her teenage son.
Well, thanks everybody. And again, thank you to John for having me here. I am the manager of the trauma and EMS outreach program at St. Louis Children's Hospital. And I just wanted to give you a quick outline of what I'm bringing here to this webinar today. I'm going to really tell you about screening and brief intervention at St. Louis Children's Hospital and a rollout that we have done of the CRAFFT screening tool and how we did it, what had to go into it, key stakeholders that we had to get, and just kind of let you know our path and our journey to universal screening at the hospital. So most of you may know what the CRAFFT+N is, but I'm going to start out if you do not. It is a screening tool for drug, alcohol, and nicotine use that was developed by Harvard and Boston Children's. It is validated for use in adolescents 12 to 21 years old. It's recommended by many different organizations. And our adolescent clinic at Children's had been using it for many, many years. Many adolescents at other children's hospitals were being screened using this tool. It's an acronym, so CRAFFT stands for different questions in the screening. I won't read all of those to you, you can see it for yourself, but there are specific questions that make up that acronym. For a long time, it was just CRAFFT, but then they came out with a CRAFFT 2.0 a few years ago and added that +N, which involves tobacco or nicotine products. So just from our timeline at St. Louis Children's Hospital to let you know our journey, we are a level 1 verified trauma center by the American College of Surgeons. And in order to become verified, we had to start doing a SBIRT, or screening and brief intervention and referral to treatment, for all of our admitted injured patients. This is a requirement to be a verified trauma center. So in 2011, we started a process of screening using the CRAFFT. And at that point, it was being done either by our trauma nurse practitioner or by a resident. In 2012, we successfully achieved our first ACS designation, and we have remained verified since then. So that was, doing the screening was a good thing, and that was just the kind of impetus for us making sure it happened, was that we had to meet this requirement. We did it for, the next 5 years, just the way that it had started with the nurse practitioner or the resident doing the screening. However, in 2017, after reviewing some research, looking into best practices, we found that many hospitals were getting better results from the screening if the bedside nurse actually administered the screening. So they were building that relationship with the patient and they were doing the screening. So our 10th floor surgical nurses decided they wanted to go ahead and do the screening. We found that our compliance wasn't optimal. We were anywhere from 21 to 67% successful with patients actually getting a screening, despite lots of re-education. The problem at the time was that we had a different EMR, and it was not considered required documentation. And so it's hard to get great compliance unless you build in for it to be required, unfortunately. So at that point, we decided we're going to have to move forward with building this into our hospital-wide EMR. In 2019, the Joint Commission released some new pain assessment and management standards, which ultimately led to our pain team at Children's also wanting to get involved in getting the CRAFFT house-wide. And this is kind of something for those of you who are looking to maybe implement a screening wherever you are, is if you get key stakeholders and powerful people also excited about it, it really helps your cause. So the pain team needing to meet a joint commission requirement was really helpful. So in April of 2019, we had a work group that started meeting to place the CRAFFT+N on our admission navigator. And if any of you have ever been in the hospital, whether you're an adult or a child, you know that there's just like a rote list of questions that you're asked. And a lot of those questions do involve health-related questions, safety questions. Do you feel safe at home? Adults are asked, you know, typically tobacco, alcohol, and those were not in our pediatric admission navigator, but we made the decision we were going to add it to the admission navigator back in April of 2019. And then 13 months later, we finally went live with it. So it wasn't a quick and easy project. It involved a lot of work and a lot of people. And I'm going to tell you more about that. So just back to the very beginning, in 2011, I mentioned we rolled this out as a requirement for our trauma center verification. And this is kind of, and you know, and John talked about this. How are we getting the screening done? Maybe when people aren't coming in for substance use needs, they're coming in for other reasons. And this is exactly what the American College of Surgeons says in their optimal care of a trauma patient, is that this is a teachable moment, right? So they broke their leg, they're in a car accident, they're basically, you know, not our prisoners, I certainly am not saying that, but you know, they're there and we have an opportunity to ask them questions. So it is required to do universal screening and take advantage of the opportunity of this teachable moment. The AAP also obviously places very high importance on expert as well. So when we initially moved from the residents and the nurse practitioners doing the screening to the bedside nurses doing the screening, we did what I felt was a pretty innovative education system for those nurses. We had approximately 50 nurses who needed to receive education on this. Because as you can imagine, it was not something they were used to, asking these tough questions. And so we were telling them all of a sudden, we need you to ask questions of these patients, and we're also going to ask you to ask the parents to leave the room. And that was a big one for the nurses, that they just felt uncomfortable with that. They felt like, oh, you know, I'm immediately like causing this rift in our relationship, and we want everything to be nice and warm and fuzzy, and I'm asking them to leave. So that was a lot of anxiety, a lot of fear on their part, because nurses aren't as used to that as, say, social workers. You know, our social workers deal with tough questions and tough conversations all the time. Nursing, not as much. So what we did is we planned a 3-hour day. And our nurses received what are called trauma hours, which are like CEUs. So whoo, they were excited about that. And so it was a 1-hour didactic lecture, which I'm going to show you some examples of what we were teaching them. 1 hour of a social work roundtable discussion, where the social worker sat with the nurses and talked through things like, what do the laws say in our state about patient privacy and adolescent right to privacy? How do they ask a parent to leave the room? So that social work roundtable was huge. And then we had 1 hour of a simulation lab, which I'll explain a little bit more as well. So these are just a few slides that were in my original didactic lecture that I gave to the nurses, basically explaining to them, why are we doing this? And also, why are we asking kids as young as 12? Because that was like, woo, blowing their mind, right? You want me to ask a 12-year-old if they drank alcohol? No, you know, that's just crazy. So we really needed to do some just didactic education with them on the statistics related to substance use in our country. So again, I won't read all these to you, but I'll just show you that these were some of the things we were teaching them, that, you know, the average age of initiating drinking is going down. And these are things that they had never been taught, had never been shared with them. Talking about, from my perspective as a trauma nurse, the likelihood of substance use correlating with some type of injury, you know, the importance of understanding that. Motor vehicle crashes and alcohol. So we made sure they understood that the expectation was going to be that parents will be asked to leave the room. And honestly, we kind of had a surprise because we thought that the nurses were already doing this, because there were questions in the admission navigator, like, do you feel safe at home, that they were asking and answering, but then never asking the parents to leave the room. So it was really eye-opening to, I think, a lot of nursing leadership that the nurses had not fully been trained on communication techniques, how to communicate with families, that, you know, in the beginning of all these questions, letting them know, you know what, there's going to be a time at the end of this that we're going to ask you to leave so we can ask a few questions in private. And so there just really hadn't been training on that. We also, just to be clear, we don't force a parent out of the room, right? If a parent refuses, we gave the nurses some talking tools on attempting to explain again and trying to re-explain the importance of adolescent privacy during these questions. But we trained all of the nurses that if a parent continues to refuse to leave, then you just document, not able to do it. And I'll tell you how we're doing that now as well. I wanted to throw in a few pictures because I thought these were fun. These are actual pictures from our simulation lab. We had a parent and a child from our Parent Advisory Council and our family partners come in. And these adolescents blew us away because we gave them kind of a script, like, okay, patient number 1 is a patient who says, yeah, sure, okay, I'll answer the questions. Patient number 2 is one who's like, you know, too tired and too busy on their phone, so they don't even want to answer the questions. And mom number 3 is one who says, why are you asking these questions? Do you know something I don't know? You know, so we had all kinds of scenarios, and the parents and the adolescents were great. So there's one mom and her daughter, and then the girl in the pink vest is a nurse, practicing asking the questions and asking a parent to step out. And then at the same time, this is our simulation lab at Children. So while one group was in the simulation lab doing the questions, the rest of the group was out watching, and then we would switch and vice versa and have some discussion about it. So I think that really helped, that role playing, that understanding that this was new to all of us and we all need practice. So that was back in 2017. And at that point, our intent all along was to transition this to all patients and not just injured patients. The feeling really was, if this is what's right for injured patients, isn't this right for all patients? And of course, we all agreed, but just knew that it was going to be a hurdle. And it was, but we got there eventually. We also transitioned to a new EMR in approximately 2018, which was part of the big hurdle. So this was our big work group. So this is everybody we had involved to get the CRAFFT+N screening to be required documentation on the nursing admission assessment in our electronic medical record. You can see this is a large group. Hospitalist physicians, clinical information systems, our chief medical information officer, I already mentioned the pain team. We had the surgical floor nursing and nursing leadership represented since they had been involved in doing the screening for many years. Quality, safety, and practice excellence, social work, clinical education, our parent family council, and then we actually had an adolescent medicine provider, Dr. Katie Plack, who is a wonderful advocate for adolescents, and having her involved in the planning was essential. We had to give a lot of presentations and explain why we were doing what we were doing, and just continue to constantly get buy-in from nursing leaders, social work staff meetings, educators, clinical information, and ultimately our Children's Medical Executive Committee. The physicians needed to know that their patients were going to be asked these questions. So integrating it into our EMR. This is what the CRAFFT+N looks like in our electronic medical record. It is what's called a cascading format. So this is kind of small, and I apologize, but the way the CRAFFT+N works is there are questions in the top section that are during the past 12 months, how many days did you drink, use marijuana, use tobacco, and basically if all of those questions are 0, then the bottom questions don't cascade, and the screening is considered to be negative. But if they answer positively to any of them on top, then the bottom questions will cascade. There's a total score. For the CRAFFT+N, a score of 2 or higher is considered to be a positive screen. This is a great part. If the patient is a 2 or higher, something that's called a best practice advisory pops up. So the nurse doesn't have to remember, oh wait, if it's 2 or higher, I need to order a social work consult. This automatically pops after they do the screening to say, hey, ding, 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 this patient has a score of 2 or higher. Please remember to order a consult. And so they can go ahead and say order, accept, and move on from here, which is a lot easier for the bedside nurses. This is what the providers see in the summary report view, so they can see the answers to the questions that their patients provided. And then one final thing that we added specifically at the request of the pain team as a result of opioid prescription tracking Joint Commission requirements is if we have a patient who does screen as a 2 or higher and they have opioid medication in their discharge prescriptions, this pops up just to basically say, hey, reminder, this patient screened at risk. Consider using alternate pain management or contact the pain team. Now, this was something that we tracked pretty carefully because we know that there are racial disparities when it comes to pain management. We know there are disparities when it comes to different diagnoses. And we really wanted to make sure that providers weren't getting this and then just canceling opioids when the patient actually really needed opioids. And so we tracked this and did not have very many patients where this popped up, but I think that this is very important. We did ultimately, I think, end up having 3 pain consults that probably wouldn't have been ever ordered unless this BPA had popped up. So after we went live, we had 30, 60, and 90-day PDSA cycles where we plan, do, study, act. So we looked at our results, we looked at issues that had come up during that 30-day period, and then we tweaked it and we kept going for the next 30 days. There are still reports that we're working on developing. We wanted to track that auditing of the BPA, opioid prescriptions, and we wanted to make sure that the patients who screened positive actually did get the social work consult. Because just because you put the order in doesn't mean it actually happens. And I don't know if I included this, but it was a surprisingly low number that ended up not having the full SBIRT. We had a few times where the patient was ready to get discharged, and we've always said, do not delay a discharge just because this hasn't been completed. But I think it was probably less than 6 that actually did not get completed throughout our full 90-day rollout. This just gives you a little summary of our 90 days. So 635 patient admissions during the initial rollout were patients who were aged 12 to 21 who were admitted to a non-ICU floor. We exempted the ICUs from the rollout because the patients ultimately get transferred to the floor and they'll get counted there, and they can't answer the questions typically in the ICU a lot of the time anyway. So of our 635, 58% screened negative, 18% were not done, 13% screened as positive, and 11% screened as were unable. The only acceptable reasons in EPIC, oh, sorry, I'm supposed to say EMR, in our EMR were that you were unable to do it because the patient is developmentally delayed, the patient refused, or the parent refused. Those are the 3 options that are listed if the nurse clicks on unable. Now there is a 4th option that says other, and that was something we really tracked because there were a lot of education moments for, I'm sorry, but other meaning the patient is deaf and needs an interpreter. Yeah, that doesn't count, right? We have opportunities for interpreters. So we really track that other to try and provide re-education as needed. This is just some more final data. The average age of our patients who screened positive was 16, minimum 13, max 20. 9 had the BPA fired, and 3 of those did have a pain consult. You can see the total scores at the bottom. The majority of our patients do score just a 2, but there we did have 3, 4, 5, 6. At St. Louis Children's Hospital, I think I had mentioned, what happens is the nurse does the screening, and then the social worker provides the actual intervention. And I'm excited to say that after me, you'll be hearing from someone who truly has boots on the ground versus me who just makes tables and charts. And so our trauma social worker, John, is going to be coming up after me. And I think you're going to really glean a lot from him as far as the conversations that he gets to have with patients and families every day about this. So please feel free to reach out to me. Like I said, I'm just an operations nursing manager. I think it's super important when you're going to roll out an initiative like this to find out who your champions are and lean on them. My email is there, and then I'm trying to like build my social media presence, and my social media healthcare mentor was like, well, you should put your Twitter on your slide. So if anybody wants to follow me, you can. It's not that exciting, but every once in a while I post some interesting things. So thank you so much. I appreciate all of your time.
That was wonderful, Michele. Thank you so much. And I'll make sure that our Behavioral Health Network social media pages are following you. So as mentioned, the next speaker is John Dalton, who is a licensed clinical social worker who works within the pediatric world at St. Louis Children's Hospital. So John graduated with a master's degree in social work from St. Louis University in 2015. He has spent 6 years working in mental health crisis intervention where substance abuse was frequently co-occurring, and he's a trauma social worker at St. Louis Children's Hospital.
There we go. Perfect. Thank you so much, John. I appreciate it.
No problem.
Yeah, and thanks so much for the introduction as well, Michele. I appreciate that as well. So yeah, my name is John Dalton. I've been a social worker here at Children's since about 2017. And I have been lucky enough to work with the trauma team since about October of last year is when I started my work with them. So through that, I've been able to have a lot of interesting conversations with our teens that are coming in through the door, experiencing some very difficult circumstances in their lives. I think as Michele touched on, they may not necessarily be coming in for substance abuse treatment or anything like that, but we have an opportunity to initiate contact and have some great conversations. So John, if you want to go to the next slide, I can begin. And so I think one of the challenging pieces of that, and I'll just speak to my experience, is how to initiate just to start these conversations, especially asking parents to leave the room. It's an awkward set of circumstances because up until this point in the admission, typically when a treatment team member comes in and enters the room, we're engaging the parents and they're, kind of part of the ship, running the ship and all that. So it can be a little bit awkward, but it's important to have these conversations one-on-one for obvious reasons. So I think the thing that has been most helpful for me is just kind of being calm, asking them to leave the room and being honest about why it is. Because especially now when we have so much more media attention around substance abuse specifically, I think that parents are appreciative that the health professionals that are working with their kids are wanting to engage in these kinds of conversations. So when we enter in the room, we just try to be clear about why we're there. An example would be like, hey, now that we've built rapport a little bit, and I'll typically introduce myself and build rapport with the family members as well, of course, learning a little bit about the traumatic event that brought them in, things like that. But then we'll ask them, to leave the room, and so that we can have some conversations around substance abuse with, with their kids. And I very rarely get pushback. I realize that it is a very kind of anxiety-invoking question to ask, but it's truly not something that I've ever really had terrible experiences with or pushback. But you can get a variety of responses. Some ones that have kind of caught me off guard, at least when I started asking these questions, is we'll have a parent that says, oh, well, me and my, son, we talk about everything. We have no secrets between us. And I'm just like, well, yeah, no, that's great. And I want to validate those feelings, because that's wonderful when parents have such a good open relationship. I love that. But it's age appropriate to, have some secrets with parents. I think that's, fine at that age. And I think what's been helpful in those circumstances, if any of the people who were on today experienced that, is to just kind of throw the policy under the bus, so to speak, to say, oh yeah, that might be, that might be the case, but we do have to do these screenings the same for everybody. And, making the policy the bad guy is always easy, because, You know, you can't really yell at a policy, and we can be angry at the policy together, like, oh, you know, rats, you know, I wish it could stay. I wish we could do it all together. But, you know, because our policy says, you know, we're going to have to ask you to leave the room. And that typically works in those situations. So, and of course, you know, as Michele touched on, regardless, this is not the main reason they're at the hospital. They're there to get, you know, treatment for their injuries. So we want to foster a good, healthy relationship with our families, and there is no need to be pushy or try to be, you know, sneaky about asking these questions or anything like that. We want to be a partner with our families. So you can go ahead to the next slide. Thank you. So once we kind of have the parent leave the room, and this is something that we can do and should be doing before we enter the room and have interactions with not just our patients, but our patients and families, is understanding our biases and understanding that our worldview may be different than that of our families that we go in working with. And I think the first thing to do is just to be honest that we all have biases, that it is normal and human to have biases. What sets us apart as far as growth is concerned is to be honest about that. And to say that, okay, well, here are my biases. I can, you know, make peace with those, be aware of those. And when we can do that, we can enter the room in a very nice, warm, neutral way. And respecting that we have different worldviews from families, and that my definition of success may be relatively different than another family's definition of success, and that's okay. We're here to partner and have good conversations, and if we can do that, then we've already, you know, made some good headway. And so when we go in and we start talking, or the way I do it when I start talking with my patients, is I explain who I am, why I'm there, and it's just kind of creating this non-judgmental space. So when I go in, I'll explain the limits to confidentiality. I'll tell them that we're there to talk about substance abuse because there was a positive CRAFFT screening, and we're just kind of here to further that conversation. I do let them know the limits to confidentiality, that if they tell me that someone's hurting them at home, that is something that I'll have to share. But other than that, I want this conversation to be, I want this to be a safe space. I want them to be open to sharing the information that they would want to share with me. And just kind of creating a good relationship there to start. Another thing that I do like to discuss with the patients that I work with is that I'm not going to put any labels on them. That if they tell me that about their substance use, that I'm not going to point my finger at them and say that they have a problem, or, you know, or accuse them of anything like that we're there to just talk about the substance use, for me to provide some feedback, and let them kind of steer the conversation from there. So I tell them that I'm never going to force any resources upon you or anything like that you don't want, and I'm not going to pull your mom in or your dad in and sit down and, you know, breach that trust, because that's not going to work. You can go to the next one. So once we are kind of going through the conversation, and let's say that we do have patients that share that there's some substance use going on that we may find concerning. It is important for us to kind of express in, you know, very clear, non-judgmental language, like to say, hey, here's what I'm seeing based on the information that you're sharing with me. For example, it may be that a very common one that I'll see is frequent marijuana use. So I'll say, okay, well, here's the information that you're sharing with me. Let's say that I see someone that's smoking marijuana every day. And then I'll ask what their experience is like with that, and if they'll, you know, if they feel like that's having a negative impact on their life. And I'll just typically ask, like, are you happy with how things are going? And they may say yes or no. We'll talk about challenges that come with, you know, using marijuana every day, whether that be financial, you know, challenges to that, or getting in trouble frequently is something that comes up quite a bit. Getting in trouble at school. Those are measurable things that we can kind of sit down and put on paper with our teens, that can help them kind of see things from an objective third-party perspective. Here's some things that maybe going better that may be causing, trouble for you right now. And for them, I think it's just kind of weighing it as a cost benefit analysis at that point, to say, what would be some of the benefits of kind of working through these issues and explaining what substance abuse treatment looks like. Knowing that not every version of substance abuse treatment is going to be a 28-day rehab program inpatient. Sometimes in discussing when sharing, their use about substances, the why they are using substances. A frequent answer specifically with marijuana use will be like, well, I use it when I get angry. I'm just like, okay, well, that's great. And so we'll talk about the cost benefits of that. So if they say that they use it so that they don't get angry, well, what would happen if you got angry? I said, well, I could punch a wall. I could, get upset. I could, break something. I said, okay. But what if you're in a situation where you don't have access to marijuana, or for whatever reason, it's important to build coping skills that are healthy, that you can use at any time. And that's something that I think has got a lot of positive responses from me. So then we'll ask, after kind of going through those motions, if they're interested in substance abuse treatment, is that something that they would like? And the important thing about that question is that if we force people into these kinds of programs, a lot of times they're really not super effective. If there has to be a motive for change, there has to be a motive to engage in therapy services and substance abuse treatment. Otherwise, it's, kind of seen as a punishment. And that's really not what we're trying to do here. We're not trying to punish anybody. We're trying to give these teenagers what may be their first clinical interaction with a trusted professional. And we want to honor that. And so, so to do that, if they, say yes or no, if they would like, treatment services, that's great. A lot of times we'll, kind of, if they do want treatment services, I will offer that it's beneficial to bring the parent in. So I'll say, well, is that something that you're interested in? Because an adult is sometimes going to be something they need to access services. A lot of times they'll need parental consent, things like that. So we'll offer to bring them in and sit them down. And sometimes they say yes, sometimes they say no, and that's okay. If they say no, there's phone numbers and hotlines that they can call to kind of get support in the moment. There's school counselors that they can utilize as well. There's all kinds of services that they can do. Now, if they say that they don't want services, and let's say I may even have some concerns about some of the things that they've told me, I still want to make sure that I keep that conversation confidential and trusted. So a lot of times, rather than force the issue, I'll ask if they have a trusted adult that they can go to for help and support. If that's a parent or a grandparent, that is a next step that they can go to there. And go next slide, please. So even in some of these conversations, regardless of the outcome, we're getting an opportunity to build rapport with kids and talk about their lives. And we will learn about their substance use. We'll learn about their personal relationships with friends and family members. Sometimes we'll learn about their lives in regards to if they're experiencing mental health crises, which sometimes is a lot of the reasons that they're using substances in the first place. We'll find out that there may be homelessness or housing issues that they're struggling with, that they're not getting enough food in the home, that they're having some difficult, relationships, personal relationships, intimate partner violence relationships, things like that. You never know what you're going to get, but you're building a good, healthy clinical connection, and hopefully setting the table for them to access services in the future and building trust within the healthcare system. As far as things that may be good to consider moving forward with the CRAFFT as well is the possibility of having it be a self-administered, like on a piece of paper, is something that we've discussed in the past. In previous work that I've done with new moms, That's how we administer postpartum depression scales. You know, we don't want to put anybody on blast, you know, or anything like that. But the logistics of that can be sometimes challenging, specifically, you know, for the bedside nurse who will be providing the initial craft. The logistics of asking the parent to leave the room, dropping off the piece of paper, stepping out, and then coming back and collecting that piece of paper all in that time frame, while that person is juggling other patients. It could be a challenge, but it was a thought that we've had discussion around and considered. And that's about it, guys. That's all I have for you today. I am more than open to, if you guys have any questions or if you'd like to reach out, I left my email below. My Twitter is not especially interesting. It's pretty much just, you know, video game stuff and, you know, guitar stuff and all that. So I don't want to bore you there, but do feel free to reach out. And I very much appreciate your time and being included in this webinar. Thank you.
Thank you, John, for sharing all that and really your observations from on-the-ground work within Children's Hospital. I think it's, like I mentioned at the beginning of this webinar, it's, I think, really important to think about a really top-down approach and really thinking about, well, how can we implement this largely, but then what does it really look like on a one-to-one level? So your discussion on that was very helpful. So thank you. So yes, to go on to our next wonderful speaker, we have Dr. Fred Rottnek. He is a professor and director of community medicine and family medicine and a program director for addiction medicine fellowship at St. Louis University School of Medicine. Dr. Rottnek is a professor, what I just said, and the medical director of the physician assistance program. He is a graduate of the St. Louis University School of Medicine and the Master of Arts in Healthcare Mission program at Aquinas Institute of Theology. His clinical practices currently include addiction medicine and correctional healthcare. He teaches in the School of Medicine, the PA program, the Center for Interpersonal Education and Research, and the School of Law. Board certified in family medicine and addiction medicine, he is the medical director for the Assisted Recovery Centers of America, or better known as ARCA. He serves on the boards at St. Louis Regional Health Commission, the Archway Institute, and Alive and Well Communities. Dr. Rottnek is the program director of St. Louis University's Addiction Medicine Fellowship.
I was furiously rearranging a few of my slides, and I will send John the new updated ones. After the previous two presentations, because I realized we were kind of going from the sacred to the profane here. But we're going to take a look at integrating substance use disorder into juvenile justice centers and primary care. Because as I love to say, if it works in a jail, it can work anywhere. For 15 years, my practice, or my Clayton office as I called it, was the jail and juvenile detention in St. Louis County. And I've recently gotten back into correctional health care by becoming the medical director at the city juvenile detention facility. I love this work, and what I'll be talking a little bit about is bringing that trauma-informed lens to this work. And again, though I will be talking mostly about juvenile detention, the work that I'm talking about will work in any outpatient clinical setting. Let's see here. My favorite picture, one of my favorite pictures in the world, and many of us have seen this, is the pair of aces tree. I love icons and visuals that can kind of center us. And as John mentioned, a lot of this work has to be self-awareness, what kitchen table conversations we're bringing forward into our work, and kind of really framing why are our patients in the situations that they're in, whether it's trauma, whether it's juvenile detention, and how can we have the most generous spirit in addressing the challenges and the behaviors they may be exhibiting. And the pair of aces talks about not only what's above the soil in terms of adverse childhood experiences, but also the adverse community environments that often contribute to what gets displayed up on the top of the tree. And one of the advantages I have, though many people would not think of it as such, in work in a juvenile detention facility, is that the parents are already not in the room. So we're good there. And as long as we're providing a calm, supportive environment for our kids in detention, we often find that they will tell us more than we want to know. So the goal is creating that trust, letting the kids that we care for in a detention facility know that we're there to take care of their health-related needs. And believe it or not, some very good things can come out of that. I want to mention briefly one of the detention standards that we use in both the city and the county is the MAHCM screening inventory. And this is a Massachusetts Youth Screening Inventory. It's something which is available on a PC laptop. And it's a set of, we'll go into that in a minute. First, I want to mention for people on the call tonight who aren't familiar with juvenile detention and some of the standardized processes that are expected as a state-supported institution. One of them is that kids who come in detention, it's considered kind of a children's home, which means that kids have to have a physical within 5 days, which is great because for many of these kids, it's the first time they've had a physical in a very long time. And part of that physical and screen includes a substance use disorder screen, but one of them also includes the MAHCM. Again, this is for use between 12 and 17. And the MAHCM-2 is a way of asking 52 yes/no questions. And what this is kind of a behavioral health fit for confinement light. All the kids who come into the detention in the city and the county sit down and take this as soon as they know they're staying. And it's a way to take a look at 7 different scales, and those scales are listed here. The way it's used practically when a kid comes into detention is that it can identify some red flags in terms of risk for a youth, and that idea of who's at greater risk for self-harm or harm of others, and it helps with housing decisions. And I mention this because it's a very useful thing to utilize in a housing situation, whether it's detention or otherwise, and it might be worth looking into for some of the folks on this call. Now, the health screenings that are state mandated, these are some of the things that we are required to ask and required to find out about the kids who come into custody. Again, keeping in mind that many of our kids that come through our doors are kids that do not have regular physical health care, behavioral health care, dental care, and other issues. So this is, oddly enough, an opportunity for intervention to work with kids and to find out some needs they may have and to address. Missouri does some things very well, and one is our model of working with what's called a youthful offender. We do not invest in big prisons in Missouri for kids or work forms or other things. We tend to have a more patient-focused model and kind of an occupational health approach to how do we help kids be successful? How do we help kids learn the life skills that they may not have that ended up in behaviors that got them into trouble with detention facilities? We already talked about the CRAFFT, which is fantastic. So what I pulled forward was from, believe it or not, a grand rounds I did yesterday for the staff at St. Luke's Hospital, which focused more on, once we do the screen, how do we do the pivot? And John talked about this with some of the questions that he has with patients and their families. I pulled these questions, believe it or not, even though this was for physicians at St. Luke's yesterday. One of the courses that I teach at St. Louis U is clinical interviewing for the first-year med students who have to be reminded that they knew how to talk to people before they came to medical school. Clinical interviewing is talking to people maybe with a little more directed purpose. So in today's age where students tend to be texting more than they tend to be talking quite a bit, I've learned that I have to be really explicit in giving some of the language around these pivots. So I want to share them with folks who are on the call tonight, because some of these are questions that we might not be comfortable asking. When I was in medical school in the early 90s, it was all about taking a sexual history and how do we use our words there. In today's world, we're still in medicine trying to get comfortable asking questions about substances. So after the screen, here are the next questions. If you've got a positive screen, and we talked a bit about what that looks like with the CRAFFT, ask more focused questions, and they could be things like this. And I have a blank in here because these work, whoops, excuse me, pretty much with all the topics and all the substances we're talking about. Granted, my career has been homeless healthcare, correctional healthcare, and addiction medicine. I just assume everybody uses everything. And the reason I do that is because it takes the leading questions out of the conversation. We all know that we've all seen providers who say things like, you don't smoke, do you? Or you don't drink, do you? You don't use street drugs, do you? Okay, well, we know that somebody's going to say, whoa, slow down. Yes, I do. So I like to ask questions like, tell me about your blank use. And we'll see that here. For tobacco, so tell me about your tobacco use. Describe your tobacco use. If somebody's not using, great. Like John said too, just say, this are the things I ask everybody. I'm not making any assumptions. Examples of more focused questions about tobacco use. There you go. With kids at detention, the last thing they need to hear Dr. Fred tell them is stop smoking or vaping because it's bad for you. What I will often say is, well, you play any sports? Are there things you do outside? Have you noticed any changes in your athletic performance after you vaped or after you smoked? And we leave it there, okay? And we talk about what that might look like moving forward. Same with alcohol use. When did you start using it? When would you like to stop or cut back? Marijuana, cannabis, CBD oil. CBD oil is only there for pharmaceuticals at truck stops, okay? Nothing against truck stops, but if they got a big sandwich board out there on the side of the highway next to the gas pumps, it's probably not where you want to go for your medicinal outreach, okay? But again, more focused questions. These are ways that you can ask. And then I often, with my kids, I'll talk about street drugs at detention. Another way to phrase that is use of medications not prescribed to you. Have you taken somebody else's prescription meds? Again, these are some nice questions to ask after the pivot. Prevention tools, I like to include some of these that are local as well as some of these that are national. These are all patient-facing resources that will give everybody on this call language to get more comfortable asking difficult questions. I would also strongly encourage folks on this call, especially if you're looking at ways to work with youth in your own life in a non-clinical context, don't make it the drug talk. Make it questions that you ask every time you check in with your kids. What's going on? What's going on with your friends? What are your friends? Are your friends drinking, smoking, etc.? Tell me about it. These are all ways we can normalize these conversations around health and flourishing. And then finally, some lessons learned behind bars. Know your team members, value their lens, and integrate their expertise into your work. Working with substance use disorders, particularly with youth, it is a team sport. Nobody can do all this work by yourself. We're fortunate in today's world, many of us have other professionals we can rely on. So know the team, know what each member contributes, know when you can call on other colleagues for help. Screening isn't one and done, okay? Honest screens, like honest conversations, depend on trust. You might get different answers depending on how long you've seen your patient or known your patient or the setting in which your patient is seen. Michele's point was excellent about these kind of screens probably are not going to work well in an emergency department, especially with trauma, a kid's in pain, a kid's no good questions happen in the emergency department. They happen when things are quiet, things are more stable, and kids feel comfortable answering honestly. And even though you may know what the diagnosis is, still do your screens. because you get your screens in there, you get them into the medical record, you get your numbers, you get to know your population. And finally, don't feel like you're opening a can of worms if you're doing a screen, if you can't provide a full assessment or a full intervention. That's why we have teams. So this is a chance to kind of get a conversation started. I love my patron saints. St. Augustine of Hippo, 300 AD, early father of the church, had a wild early life, left his mistress and his child to the care of his mother, St. Monica. My favorite line of his is, "Dear Lord, make me pure and holy, but not yet." So I think he's a great patron saint for this work. St. Monica, no joke, patron saint of long-suffering mothers. So good example that I think we can pull forward. So thank you very much. Here is my email address. And I'm always happy through our Addiction Medicine Fellowship to see if there's any way we can support the work of others in our region.
Wonderful. Thank you so much, Dr. Rottnek, for all of your great expertise around the juvenile justice system, primary care. And I loved your statement about if you can do it within a prison system, within a jail, within a detention center, from the other place. So wonderful. Thank you again. All right, so as I mentioned, our last speaker this evening is Maggie Graf. Maggie is the Director of Health Education at IFM Community Medicine. Maggie has been with IFM Community Medicine since 2018. She is currently the Director of Health Education and loves working with teens and young adults. She received her Bachelor of Science from St. Louis University, and she will be graduating with her Master's in Nursing Education from SIUE, or Southern Illinois University, Edwardsville, in December.
So thank you, John. I've really enjoyed watching everyone's presentation. There are some great information that everyone shared that I plan to use with my own patients. So again, as John said, my name is Maggie. I'm a registered nurse. I work with IFM Community Medicine, and I am the Director of Health Education. So to give everyone a little bit of background, IFM Community Medicine is a medical nonprofit with 20 clinics across the St. Louis City and St. Louis County area. We also have one organization located in St. Charles. IFM partners with a number of organizations, including school districts, children's agencies, shelters, and early childhood centers to provide medical care to populations that for a number of reasons don't generally have access to health care that is consistent and comprehensive. To give you a little bit of background on the patients that we serve, last year we saw patients ranging from 2 months to 94 years in age, but about 80% of our population is under age 21. About 15% of our patients are uninsured, whereas about 65% of our patients receive either Medicare or Medicaid. This number is a little bit higher in some populations, including our youth and young adults, who tend to have some kind of public assistance at some point in their lives, but as they age out, they usually in their early 20s no longer have any kind of bridge. And you can see some of our partners on the right. So in this presentation, on screening for drug abuse in our youth population, whenever possible, we really like to utilize formalized screening tools. In some of our more simple patients, we really like to use the DAST-10 screening, for example, or the drug abuse screening tool, which was shared with us by the NCDA. A little shout out to our friends over there. But it can be a little difficult in our team. So I choose the barriers that we face. We tend to see these youth patients in one of two places. The first is in our school-based clinics. The other is in our shelters. So in terms of our school-based clinics, they usually present to us for one of four reasons. So the first reason is a general physical or a sport physical, which is required by school to participate, either to attend school or to participate in some kind of school-sponsored sports team. We are youth for various immunizations and vaccinations, again, things that are required by the state. We do see staff and students for urgent visits, so if they are feeling under the weather, they might stop by if they have a sore throat. Certainly in the age of COVID, I assume we'll be seeing a lot of runny noses. And then finally, schools do require paperwork for certain conditions. For example, asthma action plans in our kids with asthma. So our nurse practitioner either helps develop or helps to obtain the necessary information to put together that paperwork. We do face a lot of challenges in our school-based clinics. The first is stigma. We've heard from a lot of the kids that we went in various locations that at school they often feel embarrassed to leave class to go see the nurse. They feel that, you know, everyone is going to wonder what's wrong with them. So we certainly have to find ways to bridge that gap. Awareness is another issue. We find that we just have trouble getting the word out there, services that provide. So whether it's teacher, administrative staff, or the parents, we find sometimes that they're not aware that there is a nurse practitioner, and maybe they're not aware of the services to provide. Is always we have consent from our parents or our caregivers in order to see and treat all of the youth. Through our school-based clinics, anyone who has or has had a child in school knows that there are about 1 million forms that you have to fill out at the beginning of every year. Stuff gets lost, people are busy, and so they don't always make them, the consents don't always make their way back to us. And finally, it can be a little bit challenging to establish relationships with parents and caregivers. Unlike teachers, you know, we may only be on site for half a day or a couple days a week. And we may not be there when drop off or pickup occurs. And so often, you know, we're having to pick up the phone and that's our only opportunity to communicate with parents and caregivers. To address these issues, the thing that we found is successful is just establishing a presence. We try to every week on the same day and just be there. We select celebrities so they will know us if they have an issue. We also work really hard to develop relationships with our schools. So this includes teachers, administrators. We are not there all of the time. Maybe we don't have the opportunity to build trusting relationships with the youth that we see, and so we really rely on the school staff to kind of be catching any kind of issue, whether it's medical, psychiatric, or an issue with substance misuse, that they are able to identify that there's an issue and that they know that we are with further assessment. Right. Thank you. Let me know if you have any other issues. I'm sorry about that.
Okay.
So you guys let me know if you hear me cutting out. I'm sorry, I don't have the best internet. So we work hard to ensure continuity of care. For us, this means sending the same nurse practitioner or provider every week to the same site. So for example, we have our nurse practitioner, Linnell, who is awesome, and Linnell tends to work with a lot of our teens and young adults. And it's really important to us that it be Linnell that shows up week after week so that she can build relationships. And that she can be there when she says she's going to be there. Sometimes we often say you can always come back and see us next week, and it's important that you see that same face. And finally, interestingly enough, and it won't come as a shock to anyone, but it's really hard for teachers to get all the supplies that they need, and the same is true for school nurses. So Linnell works for her schools to make sure that she's bringing supplies, everything from lotion to Band-Aids to over-the-counter medications, the things that kids go to the nurse's office for. Sometimes we talked about stigma. This can even act as like an excuse, a reason that they might go see the nurse. So, oh, I'm just going to go grab some lotion, or oh, I just need some Tylenol for a headache. And we find often that once we can get them in the door, we can see how they're doing, catch up with them a little bit, or even kind of establish a relationship. So you can go ahead and change the slide, John. Thank you. So the second place that we see a lot of our youth are in our community-based clinics. There is any number of reasons that a youth might be living in some kind of emergency housing situation. They may be homeless, which is particularly true in our 17 to 21-year-old population. They might be experiencing some kind of housing instability. So this could be that they normally crash on a friend's couch and that's no longer an option for them. You know, they were staying with a significant other and they broke up. And the last thing that we see a lot of is unhealthy family dynamics. So it could be abuse, it could be neglect, or it could be honestly that the parents are having a difficult time. I've seen everything from house fires to just a lot of chaos going on in households, reasons that, you know, they need to drop their kids off for a couple days or a couple weeks while they get settled. So for these kids, we, you know, see them for new resident physicals. So in the last presentation, we, you know, talked a little bit about needing a physical within 5 days. This is certainly true in our shelter populations. Immunizations, but in this case, mostly for employment. So hepatitis A vaccines, they may need a TB test. Urgent visits, so especially during cold and flu season, we see a lot of sore throats, runny noses, and coughs. We also see a lot of urinary tract infections, and though they kind of touched on it in the first two presentations, though they come to us to be treated for urinary tract infection, we often find this is a great time to catch up with them and see how they're doing and maybe even perform a physical. And the last thing that we see a lot of is medication refills. So youth may have run out of an inhaler or in some cases psychiatric medicine. This can be a little bit challenging for a nurse practitioner. We have to verify a lot of these medications, but sometimes with support, we can kind of bridge their needs until they're able to get back into their healthcare providers. John, I'll have you. Perfect. We do face some unique challenges with this population in particular. The first is just time. You know, we all know that teenagers are busy or they feel very busy. And so it's hard to get them to step away from what they're doing to even talk to us for 15 minutes. So often we're really having to capitalize on the time that we do have with them. The moment that they kind of do put down their phones, then we say, hey, just give me 5 minutes. Resistance is another issue that we face. We just have youth that don't want to come with us. They don't want to be screened by us. They don't want a physical from us. If they do agree, sometimes it's reluctantly, and we don't get very honest answers. Trust is a big one. You know, Dr. Rottnek talked about the ACEs, and with our youth population, they have faced a number of adverse childhood experiences and a significant amount of trauma. So trust is hard won. They're also kind of have their guard up. You know, they're living in a residential facility with a group of people that they've never met before. And so we really have to work hard to establish trust. And finally, one of the biggest things we face is just unmet needs. So food, shelter, clothing, or other personal or hygiene items. This is just kind of on their mind. Until you can address needs, this is kind of all they think about, and it might be all they talk about. So for us, you know, it may be referring them to one of the social workers on staff, or some of our sites have food pantries or clothing closets. So Epworth, for example, at their drop-in center has a clothing closet with all kinds of great clothes, also some goods, and you can take home some hygiene items, shampoo, conditioner, toothbrushes, toothpaste. So we'll often either tell them that as soon as the appointment's done, we'll walk them down to the clothing closet, or we'll even let them go to the clothing closet first, just so we can kind of get all of that squared away. So in this population, it's really important that we establish a presence. We talk a lot about meeting them where they are, literally and figuratively. So it's really important to us that when we open a clinic, that we open a clinic within the walls of the organization. Worth was an example that I gave. It's really important that we be in that same building. So at the drop-in center, our clinic is upstairs. If we're at Covenant House, our clinic is in the same building that they live in. If we're out at Youth in Need, our clinic is located across the street from their shelter. So it's really important that we be accessible to them. It's also important that sometimes we find them. Some of our business comes from just going downstairs or walk building and checking in with people. How are you doing? How have things been? You know, introducing ourselves or saying, hey, is there anything you need? I can take care of you right now. It's also really important that we develop a relationship with our agency staff. I talked in the school-based health setting about us not being there 100% of the time, and this is definitely true in our shelters. They know the agency staff, they love the agency staff, and they trust the agency staff. And so it's really important that if a staff member is working with a youth and they disclose some kind of substance misuse, that the staff understands that we are there to support them. We also ensure continuity of care in this space. We send the same nurse practitioner every week. Another thing that's really interesting that we found is if you offer giveaways. Last winter we were doing hand warmers and hand sanitizer. Last fall Linnell was giving apples. Some of these things are a little bit trickier with COVID, but we find that it kind of attracts youth to our clinic offices. It gives them a reason to come see us, and while they're there, they often share some other needs that they may have. You know, teenagers, people love stuff. I also think it leaves them feeling like they gave us information and they gave us their time, and so we're going to give them something in return. And finally, I think it helps with stigma. Nobody's asking why you're going to see the nurse if you tell them, oh, I'm going to go grab a hand warmer. That really works for us. I know this isn't always possible in every setting, but certainly if you do a kind of outpatient center, that might be something worth. Finally, in our youth, so it's really important to us. Know our faces. So this might mean that we literally, like I said, go down and sit on the couch and watch TV between appointments. This might mean that we, if they're playing a game, that we sit down and participate for a little while. We also try to create educational activities. So last year we were doing a series called Tasty Treats where we would make healthy snacks with the kids. It was really fun, it was really hands-on, and it was a way to sneak in some good education about nutrition. We also hosted a couple trauma-informed yoga nights, and so it's really important to us that we not only organize these events, but we be there. So they see our faces and maybe get to know us in a different space. I talked a little bit about the barriers to formal screening. Certainly some tools that are long are challenging for us. As I mentioned, sometimes Linnell and I only get, 5, 10, 15 minutes of their time before they're ready to get out the door. We also face a lot of resistance in terms of just wanting to participate in the screening at all. And then finally, we have a lot of hesitance to provide honest answers. And this is for a number of reasons. They might be fearful that we'll share this information with the police. They might be fearful that we'll share this information with the agency staff. They're worried about losing their jobs, worried about getting kicked out of housing. And so we really have to establish that non-judgmental openness. We do try to utilize shorter screenings whenever possible. So though it's a mental health screening, the PHQ-2 is a great example. We can start with 2 simple ones, and if either of those questions is positive, we can move to the PHQ-9. We also have a lot of success in kind of finding a back door to honest answers. So when we are asking youth about their medical history and kind of gathering information about their social history, do you smoke cigarettes? Do you, use drugs? We can see a little bit of information here. Usually this is, it's been 5 or 10 before we introduce these questions, gotten to know us just a little bit, and hopefully we can get them to feel a little bit more comfortable. The thing about this is that we often have people admitting to cigarette smoking and vaping. We also have some admissions to alcohol use, especially socially. And we do have youth disclosing regular marijuana use, but it's a little bit harder to get honest answers regarding substances. So sometimes we move on to exploring how they cope with stressful situations. So when you're feeling like you're under a lot of stress, what do you do? And then we can kind of discuss healthy coping mechanisms versus unhealthy coping mechanisms like drug and abuse. All right. So I have barriers to formal screening. I apologize, my new copy has barriers to referral. We have a lot of barriers to referring patients for treatment to substance use counseling and treatment centers. Sometimes, you know, we are fortunate. We do have youth that over time feel comfortable disclosing some substance use that they find is interfering with their daily lives. And at that point, we work really hard to get them some treatment. Cost is always a barrier to us. I mentioned some of our population is uninsured or they receive some kind of public insurance. Sometimes if the treatment program is covered, we have trouble with long-term coverage. Maybe they can stay for 3 days at a facility, but it's going to be a little bit harder to find them any kind of long-term outpatient treatment. And certainly out-of-pocket costs, even as low as $30, can be a deal breaker for some of the youth in our care. Transportation is a huge, huge struggle for us. We, in fact, if we were to refer someone next door, even down, we find that they just never make it there. And it may be because they don't have a ride, or it may be because just a complete discomfort with the entire process. Also competing priorities, again, these are teenagers and young adults, and they just perceive that there are some things that they needed to do, is what we hear a lot. I had something else I needed to do, or something that they, you know, felt took precedence, like work or even childcare. And finally, distrust. And this is distrust of kind of the entire medical community. You know, previous presenters discussed that sometimes these youth, this is their very first opportunity to have a trusting, respectful interaction with a healthcare provider. And certainly we hear this a lot. We hear a lot of negative experiences that our youth have had, that they just worry about how they'll be perceived and that they'll be judged. And so this can be a significant barrier for us. Some ways to address this: we always try to provide these on-site services. I talked about being in the same building. We work really hard to partner with our agency staff that maybe have some training in drug and alcohol abuse treatment. We also try to arrange transportation. So we work really hard with organizations like the Behavioral Health Network to find providers and to find referrals for our patients. And when we are fortunate enough to make that connection, we work with our agencies and also with those providers to try to get them there. It's also important that you help them make that appointment. If we just give them a phone number, we are finding that they are not completing that process. So we will actually sit down, pick up the phone, and we will make an appointment together. And finally, right now, you know, with COVID, everyone is talking about telemedicine. It's certainly something that we're exploring. Harris Stowe is a great example. We have kids who are right off a bus line, but it often takes them hours and a couple different changes of different lines to get where they need to go. So we are, you know, looking into the option of engaging providers through telemedicine so that either we can assist the youth in speaking with a provider, or our agency staff can set something up. Thank you guys so much for watching this presentation. I can put my email in the chat. Let me know if you ever have any questions, and it was a pleasure speaking with you. Thank you, John.
Well, thank you so much, Maggie. And as I mentioned to you personally, but just to verbalize it, the reason I was really happy that you agreed to speak was your organization really has such a unique perspective in working with youth, or not perspective, but a very unique way of doing it. And you're really embedded in the community. And I just think because of that, I really wanted to highlight, you know, what you were all doing and the best practices surrounding that. So thank you so much for your presentation and your time. I wanted to mention before we wrap everything up, our next webinar episode will be next week, same time, same place. It will be about linking substance use and violence. We'll be kind of talking the same thing, same perspective of top-down approach. We'll be discussing data, trends, and current efforts for prevention. So again, that's next Wednesday, October 7th from 4 to 5:30. We do have a survey that I started inputting for post presentations for each episode. Literally takes like 2 minutes to fill out, and it's really just helped me improve future webinars webinars around these types of conversations. And then lastly, I did have some resources that I did want to provide very quickly. Our wonderful Kate Barbier was the individual that was assisting with some of the technical issues a little bit ago. She's actually the program manager for a project called No CPAP. It is all about building capacity within primary care settings to treat and manage behavioral health needs for children and adolescents. Basically, it's like a consult service for if you are a pediatrician, family medicine physician, advanced nurse practitioner, physician assistant, whoever you might be within those kind of offices, to assist with mild to moderate cases surrounding behavioral health with youth and families that you might see. So if you did have any interest in being onboarded or learning more about that, the contact information is right there for Kate. I did also want to highlight that we have our CCP, or Crisis Counseling Program. If you are someone who has been impacted by mental health, or if your mental health has been impacted due to COVID-19, this resource is free for counseling and resource linkages. And we do have specific contacts for the individuals that you would be connected to based off of a population that you or someone you know might be part of. But if you did want to just call for 24/7 care, you can call that 1-800 number or do the text talk with us number as well. For anybody that's on this call that is a prescriber, there is a youth and young adult psychosis webinar series specifically for prescribing for first episode psychosis. This is Monday, October 19th from 12 to 1. And like I said, I'll be sending out this information, but this is the register link for you as well. And I will make sure to attach this flyer to the email list for everybody. And the last thing I wanted to mention is next week, a week from tomorrow, and basically every Thursday, most Thursdays at 6 p.m., Bridges to Care and Recovery, another BHN project, has a webinar series or various webinar episodes that they conduct surrounding destigmatizing behavioral health within St. Louis area churches. If you did ever want to access those, you can actually go and follow Bridges to Care and Recovery or BCR Wellness Champions, that's their Facebook page, to actually go on to any of these episodes. You can just go to their link tree. You basically just type in the URL linktree/Bridges_BHNSTL, and you will be able to go straight to the link, click on a tab, you go straight to the link to actually access the webinar. But that is everything that I have. I just want to say again, thank you so much to all of our wonderful speakers. I just want to say that all of these individuals, I spoke with them a little bit and they all said that they would be happy to speak on here other than just to share the information with you all. So they are wonderful individuals that did this out of the understanding and the passion that they have for a collaborative approach to youth substance use and really working with youth and families to strengthen the behavioral healthcare structure within the greater St. Louis area. So with that, I do want to say thank you again. Again, I appreciate it so much. All the individuals that were on this call, I assume appreciate it, but I also really appreciate it. So thank you so much. If there are any questions after this presentation ends, I will make sure that you all get those questions and get in contact with those individuals. So thank you so much, and we will close out.